So one of our first questions is, can you please provide some clarification? Is everolimus for carcinoid, and is it available now, or is it waiting on more trials?
Everolimus is an FDA-approved drug. In the world of neuroendocrine cancer, it is approved for treatment of pancreatic neuroendocrine cancers. For carcinoid, the trials are ongoing. The results of the hopefully definitive trial on carcinoid and neuroendocrine cancer, known as RADIANT-4, have not yet been released, and I think we'll all have to see. So right now, that's the status of everolimus. The drug is on the market, but insurance companies might or might not pay for it for neuroendocrine cancers that are not starting in the pancreas.
Thank you, Dr. Wolin. Is there information on carcinoid of lung or foregut is limited as well as mets to the bones? Is it because there really is limited information, or is it because treatment is the same as carcinoid tumors in midgut, hindgut?
You can start.
So let me just ask a clarification question. So are they asking about lung primary neuroendocrine
yes,
tumors?
Yes, that's lung primary.
Okay. And then about bony metastases. So lung primary neuroendocrine tumors actually are indeed, of the well-differentiated type, are actually quite common among neuroendocrine tumors. Lung and small bowel are probably the two most common primary sites. They tend to get lumped with non-pancreatic. With us having sort of learning more about the biology of these tumors, the clinical trials now are really studying pancreatic neuroendocrine tumors and other. So they tend to get lumped in this other. That's really because it would be very difficult to do clinical trials studying each of the primary sites separately. For sure, they're a different entity, and they probably have unique features. There aren't clinical trials dedicated, Ed, and I don't know if you have other comments, but to that type per se. And then bony metastases can happen with any neuroendocrine tumor site, and I think can pose clinical treatment challenges in terms of causing pain. I think anecdotally, and Ed can add to this, I think we can see different responses in the bone than in other sites, and that can sometimes pose treatment challenges as well. If you want to add to that.
I agree with everything that's been said. Just a few more points to make is that, one, there's a hint of activity of everolimus in lung carcinoid tumors. They were included in the so-called RADIANT-2 clinical trial, and it looked like there was some activity in that preliminary data. As a result, lung carcinoids were also included in the large carcinoid everolimus trial for midgut tumors. It also included lung, the one that's called RADIANT-4. And I think we all await the results on that, but potentially that may show activity of that drug in lung carcinoids. There's a lot of large trials that have been done for neuroendocrine cancers, as Dr. Kuntz said, that include lung among other sites of non-pancreatic. And it's very hard to tweeze out the information very accurately when you're dealing with small numbers and subsets of patients on large trials. But I could tell you from experience that lung cancers do respond to treatments that do work on other kinds of neuroendocrine cancers, and peptide receptor radiotherapy for people with strongly positive octreotide scans is being done in Europe particularly, and in a few sites that have it available for other sites of origin other than midgut. So I think that it doesn't mean that nothing can be done because it started in the lung, but we have to realize there's just less data. One more thing to mention about lung carcinoids is that there are typical carcinoids and atypical carcinoids. The so-called atypical carcinoids are somewhat more aggressive than the standard or typical carcinoids and are often more responsive to a variety of kinds of chemotherapy, and sometimes chemotherapy drugs that otherwise would be used for lung cancer or more high-grade neuroendocrine tumors will work on those kinds of tumors. There's also a lung carcinoid tumor with lots and lots of little tumors all through the entire lung that goes by the nickname of deep neck, and that can be treated with somatostatin analogs and with other specialized therapies. So more information is coming out about that. And I think should also mention that there's going to be a seminar in the last day of the National Carcinoid Cancer Awareness Symposium on lung carcinoid specifically, and it's going to be devoted to that, and that's going to be a conference for patients with lung carcinoma. So that's all.
Thank you. We have a few questions regarding PRRT. I'll kind of group them together and then see who wants to answer. Does PRRT damage healthy liver cells, and does it stimulate more aggressive tumor cells by mutation? And adding on to that, is there any evidence that PRRT patients develop bone marrow hematology problems and any other side effects?
So I should say that I'm not an expert on PRRT. I'm learning since it's only a few. That's it. Go away. Drastic measures.
Pull the plug.
So I'm not an expert yet on PRRT. We're trying to get PRRT to the United States, to UCLA particularly. As pertains to the second part of the question, yes, there are side effects to the bone marrow, and you really only want to give the PRRT treatment to patients with bone metastasis if you have single or a few focal lesions within the bone. If you have diffuse metastatic disease to the bones, it's probably not a good idea to do PRRT because you're going to knock out the healthy bone marrow, which produces the blood cells in your body.
Just one more comment. We actually have a PRRT center at Cedars-Sinai for mid-gut carcinoids. We're participating in the so-called NETTER-1 trial. And PRRT can damage healthy cells. It depends on the isotope which is used and on the dose of isotope. In Europe, there are PRRT trials using yttrium-90, as well as trials using lutetium-177. Yttrium-90 is an isotope which shoots out a ray which travels a little bit further. It can maybe go as far as 12 millimeters, as opposed to lutetium-177 that has a ray that can travel 2 millimeters. So that the collateral damage, if you like, with yttrium-90 is a little bit more, and there's potentially a little bit more risk for kidney toxicity or bone marrow toxicity. The isotope that we're using, lutetium-177, has a path length of about 2 millimeters of the ray that comes out, which doesn't travel too far and doesn't cause a lot of collateral damage. But nevertheless, there is potential for injury to normal cells. And as with any treatment for cancer, you have to say, what are the benefits, what are the risks, and make sure that the benefits are outweighing the risks. There are rare people in the world that have gotten leukemia or pre-leukemic changes from bone marrow injury. There are rare people that have had serious kidney injury that have resulted in dialysis, but those complications are rare. And in general, if people have lowering of blood counts from PRRT treatment, it's a temporary situation, and then it resolves over weeks or months and usually gets better without major consequences. So it's generally a relatively well-tolerated treatment.
Great, thank you. And we have a couple of more general questions. What does differentiated or poorly differentiated mean? And if you could talk a little bit about that more as a general term.
I can try talking a little bit about that. So you'll hear words like grade and then degree of differentiation, and they kind of mean the same thing, but there are some fine nuances. So degree of differentiation refers to how different do the cells look than the cell they came from. So, cancers originate, for example, if your tumor originates in the pancreas, that really started from a normal pancreas cell, and then sort of grew out of control and became a pancreatic neuroendocrine tumor cell. And so the well-differentiated cells or tumors are the more slow-growing, retain some of the features of that original cell type, and the poorly differentiated are kind of the furthest away from that original cell type and are more aggressive, grow more quickly. Grade refers to sort of grades 1, 2, and 3 or low grade and high grade sort of fall along those same, where low grade is more slow growing and high grade is faster growing. Ed, you're welcome to contribute.
Excellent.
Great, thank you. And there are a couple of questions directed towards Dr. Auerbach. One is about the GA68 trial that's, you said, mentioned was just expanded to another 300. Can you speak about who qualifies and how do they get into the trial?
So, doesn't like me.
Give yourself.
Have a selfie? Yeah. No. So, as you all, or most of you know, dotatate is not FDA approved, even though there is ample data that it works and that it's better than what is currently approved, which is the octreotide SPECT scan. The dotatate scan is cheaper, it's less radiation, and it's less strenuous for the patients because they only have to come for one imaging appointment. And most of all, it's more accurate than the octreotide SPECT scan. And all that data is available, but unfortunately all that data comes mostly from Europe, and the FDA doesn't allow us to use the European data. So we have to, in essence, reproduce the data here in the US. Our trial is set up as what we call a questionnaire study, where we look at management changes that occur based on the scan results. And we had to be able to do that, you have to get a very kind of focal, narrow approval from the FDA to use the tracer. It's called an IND, an investigational new drug, because the FDA treats tracers just like medications. So the IND that we got initially was for 100 patients. Through Dr. Woolen, we filled that very quickly. And then seeing the need for these scans, we applied for an expansion to do an additional 300 patients. And we got that through the FDA, and now also got approval from our own review board at UCLA. So we're, starting Monday, we're open again to image an additional 300 patients. Pretty much anybody that has a neuroendocrine tumor is eligible for the imaging. And the best way to set it up is to email me directly and take it from there. That was everything, right?
Yes, that's perfect. Would you like to announce your email address, or is that, since you just invited us to email you?
Okay, it's M. Auerbach, just as part of my name, at mednet, M-E-D as in David, N-E-T as in neuroendocrine tumor, .ucla.edu. And I usually respond within 24 hours, so.
Excellent. You might want to give yourself Sunday off tomorrow. There's a couple of questions about why use octreotide rather than lanreotide, and does lanreotide raise sugar levels? I think we did mention that.
What was the last part of the question?
Does lanreotide specifically raise sugar levels more than octreotide?
Lanreotide and octreotide biologically are almost identical. They both bind to the same type 2 somatostatin receptor with approximately the same affinity, have the same kind of action, and are very, very similar. It's very hard to compare the trials that were done with octreotide and lanreotide, since the criteria for response in the two trials were completely different, and you can't compare the actual numbers of months of progression-free survival. That isn't going to work because of the way the data was published. But I think they're both good drugs. Because octreotide was out first, and most people in most insurance companies are more familiar with it, it's usually easier to get approval. Remember, for treatment of carcinoid syndrome right now, octreotide is approved, and lanreotide is not yet approved. And for treating carcinoid cancer, nothing is approved, although it's usually possible to get approval for somatostatin analogs. So I think it really depends on the geographic area, how hard it is to get lanreotide approved. But it is, it's going to become, I think, more readily available in the near future, depending on how things go with the publications and the rulings of the FDA. Do you have any thoughts?
Great, and we have lots of questions about diet and nutrition. One question is, how cautious should we be with popular or superfoods, such as asparagus, kale, cactus, turmeric, in concentrated superfood supplements?
So the question was, how cautious should we be?
That was the question. I think the usage or recommendation for using supplements as superfoods.
Oh, I see. I think you should, approach that with somewhat caution, just because the supplements are not necessarily regulated. So if you're taking like an isolated supplement that has an extract of something, unless you know it's been tested for purity and potency, you don't know you're really getting that supplement. For example, sometimes turmeric supplements have been found to be contaminated with lead. There's definitely some quality control issues that I would be cautious with. And I think that we definitely know if you can get it through food, you're probably getting more benefits, because there's thousands of bioactive compounds in the food that we're not necessarily isolating and putting in that capsule. So you may be missing the most active component. We might think we know what that right component is, but actually it's another component in the asparagus that's benefiting you. So I would approach it with some caution, but I think it's definitely possible to use some of those things if you want to, carefully.
Great, and a follow-up question to that concerning carcinoid syndrome in diet. You recommended adding 25 to 50 milligrams of niacin, but the person asked, but won't that cause a worse flush if we're already flushing?
Yeah, that's a good question. So it's a very low dose, so we haven't really seen it cause flushing, but I would be cautious and see, what happens. And then the nicotinamide is the no-flush niacin, so that would probably be the best way to go. And it's clearly marked on the multivitamin or on the B vitamin supplement.
Great, thank you. And we have a few questions related to NET patients and connection with other diseases such as breast cancer. So are breast cancer rates increasing in NET patients? And is there a connection between NETs and kidney disease?
There are several intriguing papers that have come out about coincidence of breast cancer and neuroendocrine cancer. And I personally have about 27 patients who have both diagnoses at the same time. Whether it's due to the fact that 1 out of 7 women or 1 out of 8 women, it currently is in America, is getting breast cancer, and we have a large population of neuroendocrine patients, so we're seeing it, or whether it's a true increase in incidence is unclear, but there may be an increased incidence of breast cancer, and there certainly are certain genetic syndromes that are associated with carcinoid and other neuroendocrine tumors at the same time. Bottom line, I think that we have to think in our minds that if we have carcinoid syndrome, with modern treatment, as all the things you've heard about today, people are able to live for a long, long time, large numbers of patients living well over 10 years, and people can live for 20 years or more, long, happy lives, even with the diagnosis of carcinoid. So you need to take care of other things. And that means if you're a woman, you should be doing breast self-examination and getting mammography. You should get your colonoscopy. You should do other things that are good measures for early cancer detection or cancer prevention, because you have to think ahead and take care of yourself. So I think that I can't be more specific right now. I don't know if you have other thoughts.
I agree.
Thank you.
Great, thank you. And we'll go back to a nutrition question. There are a few of these. One is stevia a good replacement for sugar?
Is stevia a good replacement for sugar? I think it's a good replacement for sugar if you like to put sugar in coffee or tea. Stevia is an herbal plant that's naturally very sweet. You can grow it in your backyard, and you can add it to your tea, and so it's definitely got a sweet taste, and it doesn't have any sugar or calories. So I think it's a decent replacement. I don't like the way it tastes in baking at all, so I personally wouldn't use it for that, but otherwise I think it would be okay.
Great, and a couple more also nutrition related. Can you talk about the distinction between wild salmon or wild fish as regards farm-raised compared to farm-raised?
Sure. So what's the difference between wild fish and farm-raised fish? And I think it depends on the fish. Specifically, some fish, when they farm-raise fish, they actually do it in a way that is done where they feed it kind of more of a clean diet, and it's in a healthier environment. But generally, like salmon, for example, if it's wild salmon, it's going to have more omega-3 fatty acids and less pollutants and environmental contaminants, whereas the farm-raised salmon tends to, based on what they feed it, have not only the omega-3 fatty acids, but it also has a lot of what we call omega-6 fatty acids, which negate the benefits of those omega-3s. And there can tend to be more pollutants like PCBs or mercury in farm-raised salmon. So you're still getting the omega-3s in farm-raised salmon, but you're not getting quite as many of the benefits as you get with the wild salmon.
Thank you. And this might be for Dr. Wolin. What studies are being done with Avastin regarding the high vascular nature of nets?
The biggest trials with Avastin, which is the brand name of bevacizumab, that's the generic name, have recently been closed to accrual. In other words, the patients have already gone on the trial that are going to go on, and the data is awaiting analysis. That's true in carcinoid tumors, where there was a randomized trial of bevacizumab and octreotide versus interferon and octreotide. That trial is closed, and we're waiting for the analysis of the data. There was also a trial in pancreatic neuroendocrine cancers of everolimus plus bevacizumab versus everolimus without bevacizumab. And again, we're waiting for analysis of that trial. So we're sort of in limbo right now. There are currently trials going on with other kinds of anti-angiogenics. There are some small trials that may be going on with bevacizumab, but until we get results of those trials, it's going to be hard to make any clear recommendations about using it.
Great, thanks. And a question for Dr. Nissen. This is more of a general question about liver surgery, but is there a certain size of liver mets where you determine they're operable or inoperable, and how you make decisions based on the size of the liver mets?
It's obviously a very complicated decision, but the key elements would be that number one, you first establish what you're trying to accomplish or your goals of intervention. And it may sound like a simplistic thing, but it's really important to figure out whether you're trying to control symptoms or trying to achieve maximal tumor reduction, whether this is the only site of disease. And of course, we talked earlier about knowing a little bit about the tumor in terms of its pace and the overall biology. But if the question is simply limited to, can you take it out, there's no real absolute size. We've had 20 and 30 centimeter tumors that have been taken out if they're in a favorable location. What we mean by favorable would be that they're away from the enough healthy liver that you can save enough healthy liver that the person can recover. And as a general rule, and again, this may be too much information, but we all have about 2% of our body weight is in our liver. And so when we do liver surgery, in a person with a perfectly healthy liver, you'd like to leave behind about half, but you could go as much as 2/3. So, or to put it another way, you have to have at least 1/3 left. So it's not so much the size of the tumor, it's more how much healthy liver you have left. So as we look at a scan and we strategize how to accomplish a certain surgery, we look for mostly what are we going to be leaving behind? What's the health and what's the size of the liver remnant? And again, that's based on body weight and other things, but it has to be about 1/3 the size of your native liver. And if you start talking about more than one tumor, well, that gets complicated as well, because if you've got tumors on both sides, you still have to leave 1/3 of the liver behind. So you have to be a little bit creative in how you approach it. And that's where some of the techniques we showed can be so helpful, because those enucleation techniques remove virtually no liver. So you could take out large tumors and actually not have removed any functional liver tissue. One of the key things is to save the main structures that give blood supply and that drain bile. Those are the central structures in the liver. So it's partly liver volume, it's partly the central structures, it's partly planning how to leave behind healthy amounts of liver, and I think most importantly, it's figuring out what your goal is. Are you trying to relieve symptoms, accomplish complete cytoreduction? Are you trying to hit a home run, or are you doing this? Sometimes we're taking out a colon tumor and we just want to do as much good as we can in the liver. And part of the way we'll look at that is maybe there's tumors on the left and the right, and if we could just get rid of the tumors on the left, then future therapies can be directed at the right side of the liver, and you can leave the left side alone. So that's an example of how we might strategize a surgery to try to consolidate future treatments, with the goal being tumor control and keeping the liver as healthy as we can for years and years to come.
Thank you, Dr. Nissen. Sort of a follow-up question on PRRT and surgery. If there's a surgically removable mass in the liver and the opportunity to have PRRT, would you do surgery before or after the PRRT? Or perhaps another approach?
Well, I think that whole concept of staged hepatic therapies, or how we add up all the complementary modalities, is one that always gets a lot of debate in all of our multidisciplinary conferences. And there's different ways to phrase the question. One way to say the question: who gets the first crack at the liver? We think that the liver's healthiest the first time around, and each sequential intervention makes it a little less healthy. I personally think that's mostly related to the blood vessels. So that's why the hepatic artery therapies, they all cause some degree of detriment to the liver. So we have to be a little cautious if we're going to do a big surgery if there's been prior hepatic artery therapies. You can still do it, we just have to be a little bit more cautious. Same with PRRT, same with any other hepatic intervention, same with even ablation. So again, it's a tricky question, who should go first, and it gets back to your goals of care and whether you're trying to, what the anatomy is. If you have 1 or 2 or 3 big tumors, I really think surgery is the best, because you can get the tumors out and leave behind the native structures, the native tissue, the native bile ducts, and all your future modalities will essentially be acting on, for the most part, a pristine liver. But I think once you start injecting and infusing and PRRT and other things, the liver's not quite as healthy when the surgeon gets to it as it was to start with. There's still a lot we can offer, but it's not quite as healthy as it would have been at the first go-around.
Thank you. And a question for Dr. Wolcott. What current pain approaches are there to patients with bone mets from neuroendocrine tumors?
Well, in general, the management of bony metastatic disease, and any source of pain, you're always looking for what are the underlying mechanisms that are causing that pain, and what medical interventions or other interventions are available to help, okay? So, but I'm going to talk just about from a purely symptom standpoint. Often with cancer in general, and often with neuroendocrine tumors, we have to be very careful about use of a variety of kind of the nonsteroidal anti-inflammatory medications. And personally, I never actually recommend using them unless the primary medical oncologist kind of feels appropriate, that that's appropriate and feels comfortable with that. So what our service usually is left with, and what we usually focus on, is the use of opiate medications, okay? So we said, first of all, you're always looking for managing the underlying mechanisms of the pain and the bony metastatic disease. Secondly, you have to make sure that we're working closely with the medical oncologist to see what are the range of medications that the oncologist feels are appropriate given the patient's overall circumstances. But when it comes to simply using opiate medications, there's a wide variety of them. If this is chronic pain, and it typically is, we're often using a long-acting opiate, meaning for instance, a long-acting version of either morphine or oxycodone called OxyContin, or there are various names for long-acting versions of morphine, or fentanyl patches. Fentanyl is opiate that's delivered transdermally through a patch, which typically lasts for 2 or 3 days. So typically we're providing a long-acting opiate to try to best maintain 24/7 pain control, and then a short-acting opiate to manage what we call breakthrough pain, or when the pain gets worse. And we are looking for kind of what is the optimal combination of those two. I would say usually we find that we're able to manage bony pain as bony pain with opiate medications quite well. Now, often, I mean, opiate medications will essentially always cause constipation, and patients with carcinoid symptoms, GI symptoms, that's often a benefit rather than a toxicity. But in any other circumstance, or in general, you cannot use these medications without having a full, comprehensive bowel regimen in place to minimize the risk for constipation. One of the nurses that I worked with for a long time who was here, who's now become very well known, but many years ago declared herself the bowel queen, because in fact, when you're managing pain, you have to help people understand how to manage bowel function, specifically constipation.
Topic well familiar to this group. Yes, Dr. Wolin.
Just one other point. The biggest problems with bone metastases are first pain and second fracture of a bone that has tumor involvement. And there is the availability of medications to reduce fracture risk, medications which go by brand names like Zometa or Iridia or Xgeva, that potentially can help reduce the risk of fracture from bone metastases and sometimes can also help with pain. There are ancillary medications like that that can be discussed with your oncologist. In addition, if bone pain is coming from a solitary spot, there may be a role for focused radiation therapy at that one area. And even though carcinoid tumors in general are not terribly responsive to radiation, this type of radiation can often be effective in helping pain. So I think that there are really a variety of complementary things that could be used in addition to the opioids.
Great, and kind of a follow-up question related to that is there's been some discussion on the ACOR listserv about carcinoid arthritis as opposed to other kinds of arthritis. Does such a thing exist?
If you're asking me, I have no relevant expertise or knowledge.
Nor do I.
I haven't heard about arthritis, particularly inflammation in the joint being a problem. There's a problem of vitamin D deficiency, often in people with malabsorption and chronic diarrhea, and that can certainly cause a lot of bone pain that's not due to metastasis, but due to severe vitamin D deficiency and osteoporosis. It's conceivable you can get an autoimmune arthritis from any cancer in the world, including a carcinoid that could cause an autoimmune arthritis, but that's got to be outrageously rare, but conceivable.
And thank you for that segue into the next question, which has to do with the recommended vitamin D levels. That would be a nutrition question for what you recommended vitamin D supplements. And so if we're having our vitamin D tested, what is the recommended level that we're looking for?
That's a good question. So the recommended level of vitamin D on the lab test will say 30 to 100, so it's a huge range, and we definitely know if you're below 30, you're insufficient. What's the right number for bone health and for people with cancer? We don't really know, but maybe somewhere between 40 and 60 nanograms per milliliter as a blood level is just kind of more in the middle and a better option. And how much vitamin D do you need to take to get to 40 to 60? It really varies per person, but most people probably need to have about 2,000 international units a day to have a level that's consistently above 30. But there's a lot of variables, like if you have malabsorption or, you know, just there's a lot of different variables, even with genetic differentials in terms of how you absorb and produce vitamin D. So it's kind of hard to say, but I'd say 2,000 IUs is probably a good amount.
Thank you. And let's see, there's a question about if a neuroendocrine patient doesn't have any symptoms at the early stage and then they become symptomatic, does this mean the cancer cell is more
So I think that certainly can happen. I've certainly had patients where they become symptomatic over time, and I don't know that I think we know that neuroendocrine growth and pace and even probably hormone secretion can change over time. I think that's more inherent to the biology of the cancer than a reflection of the hormone status, but I think that we know that the pace can really change, and it's really hard to predict that. We don't have great predictors. I've also had patients that weren't previously symptomatic, and we've learned later in the course of their disease that they have functional syndrome, and that sometimes happens too. I don't know if you want to add.
If you're talking about some of the other symptoms, if the rule out or separate ourselves from the carcinoid symptoms, the abdominal pain and obstructive symptoms are a little more confusing because, the cancer can grow very slowly and at a very steady pace, but all of a sudden become symptomatic because you've reached a critical level in the bowel, sort of like a running stream that you can gradually block and there's no change in the flow, but all of a sudden 1 or 2 more rocks in the stream and it starts to become like a whitewater raft, or garden hose might be another analogy. And so these tumors in the mesentery, in particular, will tether the bowel. And it's one of the most remarkable things. They just gather the bowel up around them. We'll find a little 2-centimeter mass in the blood supply to the bowel, and it's scrunched all the bowel up around it. And sometimes it's remarkable that the person wasn't more symptomatic. And when we see that, you can really see how it would just take 1 little millimeter more, and all of a sudden a tumor that wasn't causing symptoms could be profoundly symptomatic. It may not have suddenly started growing quickly, but that channel that food was going through has now changed just enough, or the circuit, the route that it had to take changed just enough that all of a sudden it's become symptomatic. Abdominal pain, nausea, vomiting, queasiness, all these things. And of course, jaundice is another example. Pancreatic tumors in the head of the pancreas can cause jaundice, and that's well known that you could have very mild changes in your liver test, and all of a sudden a critical narrowing of the bile duct occurs, and now your eyes are yellow and your urine's dark. It doesn't mean the tumor suddenly exploded, it just reached that point where now it's very clear to the naked eye that there's something wrong with your liver.
Just one more comment. If somebody with carcinoid tumor that's metastatic has worsening symptoms, and their diarrhea is worse, for example, if the tumors have not grown on your MRI or CT scan, there's no evidence of cancer growth, and your serotonin level production and 5-HIA are remaining stable, and the diarrhea is a lot worse, rather than concluding that it's the carcinoid syndrome getting worse, there may be other competing causes for diarrhea. And carcinoid patients often have lots of other things going on in their lives that can cause diarrhea that have specific therapies. You can have bacterial overgrowth in the small intestine because very commonly these tumors start at the last part of the small intestine, and the so-called ileocecal valve has been removed at surgery, and bacteria can easily get up into the small intestine. That can be treated with special kinds of antibiotics and dietary changes that can help that kind of symptom. You can have diarrhea from infections, from things like Clostridium difficile that happens when people get antibiotics for intercurrent complications that can suddenly make diarrhea much worse. And you could have all kinds, bile salt diarrheas. There are many, many kinds of diarrhea. So if somebody's tumor is not growing and you don't have convincing evidence the carcinoid syndrome with hormone production is getting worse, it's actually worth seeing a good gastroenterologist and evaluating competing causes of diarrhea that could actually be contributing, because each one has its own therapy.
Great, thank you. And a question, I think, for Dr. Auerbach back. Could you please talk about tracer options for patients who can't tolerate gadolinium? Are there any other options?
So gadolinium is actually a contrast agent that's used in MRI imaging, magnetic resonance imaging, and has nothing to do with the gallium that's used for dotatate. Generally, nuclear medicine tracers, they don't have any side effects. The only side effect, if you want to, is the small amount of radiation that you're getting. But because the actual, what we call pharmacological dose, the amount of active octreotide analog that's used in the tracer is so small that it cannot physically not cause any symptoms in the patients. So gadolinium, again, is something that's used in MRI imaging and has nothing to do with the dotatate imaging.
There are some patients who tolerate one MRI contrast better than others. They have different brand names like Optimark and Eovist, and sometimes people tolerate one and don't tolerate another. If people actually are intolerant of MRI contrast and can't have any of those kinds of agents, as long as the radiologist is aware, it's often possible to get a very good MRI of the liver with no contrast at all using what's called diffusion imaging and other specialized techniques. But it really has to be individually worked out. Do you have any thoughts, Dr. Nissen, from your perspective?
It's fascinating. We use MRIs as our primary modality for monitoring liver tumors because they're so good at telling treated from untreated areas. And the radiologist will sometimes see movement on the scan. And when you take a breath or when you breathe during the MRI at the wrong time, it really messes up the image. And sometimes the agents that are given will affect people in a different way. They'll give a different visceral reaction so that it's harder to hold their breath. And one of the things our radiologists are great at, I think, is tailoring that a little bit to the individual and maybe talking through the headphones and things a little bit about things. But I think it's fascinating over the last few years using these complementary different modalities to follow tumors. And I think Dr. Wollen's point about even avoiding contrast altogether is one that we've toyed with, but it's harder to do that for tumors that are treated because then you're really looking for treated and untreated, but it even works for some of those. Now this concept of open MRIs, I've only seen one really good open abdominal MRI, but I'm sure it's not too far away till we get rid of the claustrophobia part of MRIs. That'll be a big victory for a lot of people too.
That's great news for all of us. And yes, the radiologists do speak to us during those MRIs. And are you still there? Are you breathing? And a follow-up on the Ki-67 that was discussed earlier. How do we know that the Ki-67 reported is the most representative for the primary tumor? And should it be retested at various points during our treatment?
So I can start with that, but Ed may have some comments too. So the Ki-67 is actually well known to be pretty heterogeneous, meaning you could sample different parts of the tumor and get different Ki-67s. It's a sort of feature of neuroendocrine tumors. So it's generally, sometimes a range is given, and usually the highest portion of that range is what dictates the grade. And, but that being said, I know that's very unsatisfying. And so we don't, and the mitotic index is another reflection of how rapidly dividing the cells are. We'll look at both of those, but again, the highest of those tend to dictate the grade, and on that we base our treatment. Ed, do you have a?
Okay, just a couple more points very briefly. One is that Ki-67 is a measure of the percentage of the cells in the cancer that are undergoing cell division. In most pathology departments, that's done by sort of an eyeball look at the specimen under the microscope, and you can say roughly 7% of the cells, or 10% or 15% are undergoing division. Or you can count a few cells. There's another technique called computer-assisted image analysis, which we're actually doing pretty routinely now, where you could sample an enormous field of cells, and you get a very accurate determination of the percent of cells that are undergoing division. And that's thought to be a slightly more representative number. One of the things that is very confusing is that Dr. Kuntz was saying that the tumors can be heterogeneous, and they can be tremendously heterogeneous, where one part of the tumor might have a Ki-67 of 2%, and another part might be 13%, and you have to call that tumor grade 2, even if the 13% was only a small part of the tumor, because that's the way the system is done. Fortunately, whether it's grade 1 or grade 2, it doesn't affect treatment, and you do the same thing. But there are cases where it can make a difference even if this tumor is called grade 3, in which case treatment potentially could be very different, and people can be ineligible for clinical trials because of that Ki-67 number. And it's a very confused situation, and I think it's probably going to get a little bit less confused over time as people are getting more used to the numbers and the problems. But it certainly should be determined, the Ki-67 should be determined by an expert pathologist and who's familiar with neuroendocrine cancers. And the second point is the Ki-67 is not something to focus on if the biopsy is done with a needle, a skinny needle. There are people who have skinny needle biopsies done through endoscopic ultrasound or just a needle biopsy specimen, which is not only not representative of the tumor because it's so big, but also it's very, very hard to calculate Ki-67, and there are people who think they have a high-grade tumor based on a needle, and really they have a well-differentiated intermediate-grade tumor, for example, and there it makes a huge difference in therapy. So Ki-67 needs to be interpreted by an excellent pathologist and really in conjunction with an oncologist who's familiar with the issues and the kind of biopsy. It's not such an easy matter that you just have a number.
I agree, and to add to that though, those exact words, Ki-67, should actually be in the pathology report. So when that's missing, or when the mitotic index is missing, that's when I go back to a pathologist or I say that it needs to be repeated. So we look for those things, and they're now really considered important pieces of the pathology report.
Right.
Thank you. I think we have time maybe for one or two more questions. There's a question about epinephrine. Should epinephrine be avoided even if in remission? And how does epinephrine affect carcinoid patients?
Well,
Go ahead.
Epinephrine is what's commonly called adrenaline. Okay, epinephrine has capability of either raising blood pressure or lowering blood pressure, depending on the circumstances. In normal life, in normal people, meaning non-carcinoid patients, epinephrine normally has the effect of raising blood pressure, and it's one of the things that can do that. But in people with carcinoid, the lowering of blood pressure effect can predominate over the raising of blood pressure, and for that reason, you can get a paradoxical drop in blood pressure that can be dangerous. This is particularly a problem who have carcinoid syndrome, who have a fair amount of carcinoid tumor in their body that is producing biologically active chemicals. And then if you use epinephrine, you can get a bad reaction. So people are generally instructed to just avoid it if they have carcinoid syndrome. The question that was just asked about somebody in remission, I don't see any problem at all if somebody has epinephrine, if they don't have any, not only no carcinoid syndrome, but no detectable cancer. Those aren't people who are going to have any bad effect from epinephrine. If they need it, they can use it. The situation where it comes up most is in a dentist office because the local anesthetic provided by dentists usually has epinephrine as a means of controlling bleeding in the mouth when they do procedures. So people should be aware of whether it's safe or not safe, and if in doubt, talk to your oncologist.
I think some people also can ask their dentist for the non-epinephrine Novocaine as well.
Right, you can always use a non-epinephrine local anesthetic if you need to. Correct.
Okay, and we have many more diet-related questions. I think we have time for one more. Can you talk about whole grain? What is it, and how do I identify it or them? Is it related to breads? And there's so many confusing things on the market, 5-grain, 9-grain, multigrain. Can you comment a bit on that?
That's a really great question, and I wish I had time to put that in my presentation because it's usually in my presentations. But basically, a whole grain means that you're getting all three parts of the grain. So a grain has a bran, a germ, and an endosperm. And the bran and the germ is where the nutrients are, like the vitamins and the minerals and the fiber and the phytochemicals. And the endosperm is where the starchy part is, the calories. And so when you take a whole grain like a wheat berry and you refine it into white flour, they throw out the germ and the bran, and you just have the starchy component left. How do you identify it? The one thing I would say is if it advertises it on the front of the package, it might not really be a whole grain. So you want to look at the ingredients, and the first word will say whole or sprouted. If there's the word whole grain is in the 5th, 6th ingredient, and the first word says enriched flour or white flour or even wheat flour, then it's not a whole grain. So that's what I look for, whether the front says 9-grain, 12-grain, 20-grain, 1-grain, it doesn't matter. Just look at the ingredients and look for whole or sprouted. And if you're buying it in the bulk section, you're gonna be able to see that it's a whole grain right there, like brown rice or wild rice or something like that.
Thank you for clearing up that confusion. Thank you to all the doctors on the panel for answering our questions.